Thank you very much, sir. May I invite our next presenter, Dr. Khaled AlShaibi from Saudi Arabia, Jeddah. So he's a master on left main bifurcations. He'll give us some 10 commandments, and after which we'll start some case presentations on this.
Thank you, Atul. A pleasure to be here, and I'm very grateful for the invitation. Just what happened? I don't know why it's not starting.
Yeah. So Rajiv, while the PowerPoint is loading up, would you like to share one commandment on? Let's have a discussion on that.
So I think the most important aspect,
most important thing which you
I would rather a small message to the younger generation is know the stent platform very well. Before you do a left main intervention, you must know your stent platform. Absolutely. And I prefer stents with 90 microns, 80, 90 microns, because we've used all sorts of stents, different thickness. So I've narrowed down to 85, 90 micron stents.
Excellent.
So stent platform, your column strength is very important. So it's a part of stent platform. So I think stent structure is the most
Very
important
important.
message, most important. And then of course the technique, and then operator is the boss, which technique you want, provisional or whatever. And secondly, when you're doing a provisional technique, even if you have 10% residual at the so-called side branch or the second vessel, it's acceptable. You can't have a perfect result in a provisional strategy with TIMI-3 flow and maybe a small lumen compromise. So the approach is different.
Great.
Yeah.
Before you go to the third one, let me call Khaled to start.
Okay, so the task I've been given is to go over actually it's missing words. It's supposed to be the 10 commandments, not the commandments, the 10 commandments of bifurcation stenting. Now, the talk I've been giving, but I think in this context, and as far as the commandments are concerned, they're almost interchangeable, because almost always when you're treating a left main case, you're treating the bifurcation. You will be having to deal with the distal left main bifurcation, whether it's diseased or not. Any intervention on left main, generally, you need to address the left main bifurcation. It may be simple, it may be complex, but it is a bifurcation. So, first commandment. Based on, and we've just heard this from Dr. Mehta, based on the totality of evidence and published data, a provisional stent strategy should remain the default primary approach in the majority of simple left main bifurcations. Based on more recent data, again, Dr. Mehta presented this in his last talk, with newer generation drug-eluting stents, especially in the left main arena, a two-stent strategy in complex true bifurcation left main cases is probably recommended. And again, I'm going to refer to the study that you've already seen, the definition study, which clearly showed no significant difference between a provisional and a two-stent strategy when it's a simple bifurcation, and yet a superiority of a two-stent strategy with true bifurcations. And again, this you've already, in the slide you have seen, Dr. Mehta just presented it, which is the DK Crush 5 study, which seemed to show an advantage when you use a two-stent strategy in the left main, that possibly a DK crush may be superior. So that is the first commandment. Second commandment, and this is important. Again, I've been a convert. I didn't used to image a lot. I image a lot more now. And I think when you're dealing with the left main, you want to get the best. You want to get the best lesion preparation. You want to optimally size. You want to get the best optimization. So I think the second commandment for me would be, when you're dealing with the left main, is image both pre and image post to optimize your result. Third commandment. Always wire both the LAD and the circ. Jailing the side branch wire is safe and has advantages. It helps maintain patency. In case of the unfortunate event of occlusion, it's the only marker of the side branch position. And in extreme situations, it can be used to rescue the side branch by passing a low-profile balloon. It also, this is more in general bifurcations, less so in the left main, but it facilitates access to the side branch by favorably changing the bifurcation angle. In the left main, usually the bifurcation angle is usually not a problem, but in other bifurcations, this may be an issue. The fourth commandment, always predilate the main vessel. I try to avoid predilating the side branch unless I'm doing a two-way, an upfront two-stent strategy. In this case, a DK crush. Obviously, I'll have to predilate the side branch because you usually start with the side branch. Or if the flow into the side branch becomes in any way compromised during my angiography or after wiring the vessel at any time during the procedure, I would predilate it. Or if it is severely diseased or calcified, again, I would predilate it. This is pretty much true for all bifurcations. Always select the stent diameter according to the size of the distal main branch, and ideally this should be determined by some form of intracoronary imaging. And select the stent length to allow for proximal optimization. In the case of the left main, that usually means select the stent length from the left main into the main branch that will cover all the way back to the ostium. And sizing, this is just a brief cartoon of why you should size to the distal main branch, because if you size to the proximal main branch, you have a very high likelihood of carina shift, compromising the subsequent entry of wires, balloons, or stents into the side branch. While if you size to the distal main branch and then do a proximal optimization, you much more favorably affect the dynamics of the bifurcation, allowing for easier rewiring and allowing for easier access subsequently of both balloons and stents should you need them. This is probably the most important of the 10 commandments, and it is always, always, always perform a proximal optimization. Remember, you have sized the stent based on the distal main branch. It is undersized for the left main. So you have to do a proximal optimization. The balloon you pick has to be sized 1-to-1 to the left main, ideally determined by intracoronary imaging. If you don't have intracoronary imaging, then please use the fractal law, which determines what the size of the left main should be based on your assessment of the size of the LAD and the circumflex. And it is the most important step, I think, in any bifurcation seating is to do an adequate pot, especially before attempting rewiring of a side branch. Because you can just imagine if you have a stent that's floating in the left main, hasn't been optimized, is not well expanded, you run the risk of this. These are two videos I think are highly instructive. So you've placed the main branch stent according to the size of the distal vessel. But as you can see, it is undersized for the proximal vessel proximal to the bifurcation, clearly undersized. Now, attempts at passing a wire, you can pass behind struts, you can pass through struts, and this will just create problems for you. It can cause vertical compression. If it doesn't do that, attempts at then not realizing that, attempting to pass a balloon could disrupt the main branch stent, lead to stent deformation within the main branch, which will be subsequently very difficult to deal with. So this is why you have to do a pot. So, let's see, this is not working. Oh, here you go. Okay. So this stent was deployed based on the size of the distal branch. Now that he's going in with a larger balloon to optimize it to the main branch. And the result is as you can see in the second frame, a stent that now is well opposed to the main branch, sized appropriately, allowing for easy passage of the side branch wire into a side branch, into the side branch without the risk of getting strapped behind that stent or through struts of that stent. I can't emphasize how important that point is. If you do rewire if you wire a side branch and then you can't advance the balloon, don't push. Take the wire out, repeat the pot maybe with a larger balloon or higher pressure and reattempt again, because in all likelihood you're either through struts or behind struts, and just pushing is going to make matters worse. This is also important when you do a DK crush. So here you'll see that once you crush a balloon, you have to crush it with a balloon that is sized to the main branch. If you use the same balloon that you deploy to crush it with, or the same balloon that you use to post-dilate the distal part of the stent in the main branch, and then you just pull it back and dilate, it's undersized to properly crush the side branch stent in the main branch. So you have to go with a larger balloon, a balloon that's appropriately sized for the main branch so that you get a good crush. Otherwise, again, when you try to pass a wire behind the incompletely crushed side branch stent, you can run the risk of running through struts or in between the layers of the crushed stent. It is extremely important to crush the stent well with a balloon that is sized to the main branch. So like I said, this is the sixth commandment. I've spent most of my time on it because I believe proximal optimization is a key step in bifurcation stenting, especially in the left main, but in any bifurcation and with any technique you're going to use. So again, once it is adequately crushed, you can see there's easy passage of the wire into the side branch. What is well, we're talking about commandments. We've gotten to the sixth commandment. I've added one here, and that is, what is the cardinal sin of any bifurcation, especially of a left main bifurcation PCI? And that's not performing a proper proximal optimization using an appropriately sized NC balloon sized to the main vessel, the proximal main vessel. Seventh commandment. This is, again, something that Dr. I believe Mehta brought up in his last talk, and that is regarding the final kissing balloons, also a point that was discussed before the lunch break. In a provisional single stent strategy for non-left main bifurcations, if the side branch is pinched but not dissected, has normal flow, you may not necessarily have to do a final kissing balloon. There are caveats where you might. With the left main, the side branch is almost always going to be the circumflex, whether it's a dominant circ, a non-dominant circ, or on occasions even the side branch, depending on the technique you've used, may actually be the LAD. So the side branch, you're always dealing here with an important side branch. There is some data, although it is not conclusive. I think Dr. Fritti pointed out this morning during his talk that if you have struts going across the ostium of the side branch, they may form a nidus for subsequent endothelialization and restenosis of the side branch. So generally, and this is a debatable point, but I think opening up the struts in left main PCA is probably important. Whenever, the eighth commandment, whenever a two-stent strategy is used, whether it's a bailout or a priori use of a two-stent strategy, you always have to finalize the procedure with a final kissing balloon and a repot to realign the deformation of the proximal stent after a kissing balloon dilatation. Ninth commandment. If you're having difficulty recrossing stent struts with a wire or balloon in any two stents procedure, never use excessive force. Repeat the pot. Either use the same balloon one-to-one with the main branch at a higher pressure or even a higher balloon, especially if you've estimated the size of the main branch and haven't used imaging to guide your selection of the balloon size. And then rewire and reattempt to pass your devices, because most of the time the resistance is because you're behind struts or through struts. Another tip is an undersized compliant balloon generally has a better crossing profile than a high-pressure non-compliant balloon. You can use that initially to open up the struts and then finish off the job with an NC balloon. The 10th commandment is unique more to left main stenting than it is to other bifurcations, and that is with left main stenting, your guiding catheter is in direct contact with the stent. And so you always have to watch your guiding catheter, especially after you deployed the left main branch stent, because of the possibility of horizontal or vertical stent deformation by the guiding catheter. Especially when you have a trapped wire, still you haven't removed this trapped wire. If you try to then forcibly engage your guiding catheter with trapped wire, the trapped wire will not allow that to happen. All that will do is cause a proximal deformation of the stent. So be very careful with your guide position and how it is interacting with the left main, especially after you've already deployed your main branch stent. And as a precaution, your last step in any left main intervention should be a final pot of the ostium, so that any deformation, should it have happened and was not recognized, is corrected. These are a few examples. This is a case of a distal left main occluded circumflex, actually, which was treated with a DK crush technique. Obviously, the side branch is small here, but you have to start with it. You can't. This is not the case for a tap or a clot. The only way I could have treated this patient would be a DK crush, starting off with the occluded circ, then crushing it in the left main and proceeding with the left main stent. This is an example of a culotte case. And this is another example of a tap technique. So you should, as experienced interventionalists, you should be familiar with all, but there are some conditions in which tap may be preferable sometimes, even to DK crush. But my default generally for the left main is usually a DK crush if I'm using an up-front two-stent strategy. But remember, for bailout, you can't use a DK crush as a bailout. Bailout means either a tap or a culotte. So thank you very much.
Thank you so much, Khaled. Just join us over here for the discussions. And welcome, Ashok. The session is on left main, and I'm sure you just come back from your left main in the cath lab. Henny's saying a hello to you over there. So while I invite our next speaker, Dr. Mamas, any discussion on this, Kirti? These are solid 10 commandments which one has to carry. I could see a lot of people taking pictures of each commandment over here.
Can't go wrong with that.
While we set up the next presentation, just a short comment over here.
This is the wrong talk. Could you put back the other talk?
I think a great talk with all the right things said.
Yes.
I think it's been repeated, most in a repetitive fashion. We've gone through all those things through the whole day.
So I follow on from my good friend Dr. Shaibi's talk, where he talked about the 10 commandments from heaven through to hell, what you shouldn't be doing. So this is going to be a talk really talking about some data around bifurcations. I've elected not just to focus around left main, but to show two illustrative cases where I think that imaging is particularly useful in these cases. I personally image in 100% of cases. Every case that I do will either get an OCT or an IVUS at the start, often in the middle and at the end of the case. So why are bifurcations important? Well, this is some data that we've published from the Ultimaster registry showing that bifurcations have much worse one-year outcomes for a variety of different endpoints, such as target lesion failure, target vessel MI, stent thrombosis, and so forth. This is some work that we published around complex PCI, and the major take-home message from this is that bifurcations with two stents have the highest event rate, you can see that they have the highest target lesion failure rate and the highest target vessel MI rate. Therefore, it's really important in these cases to undertake intravascular imaging. As we've said, I think imaging is mandatory in left main cases. We've published data from the UK showing with 30% reduction in all-cause mortality at 1 year associated with intravascular imaging for left main PCI. It helps you understand the plaque burden in main vessel and side branch. It helps you define bifurcation angles, particularly when the angiographic views are suboptimal, and helps you characterize calcium, particularly whether it's circumferential, the depth, and as we've seen in many of the cases today, guide lesion preparation and use the appropriate tool for the right indication. And this is the data that I talked about, left main intravascular imaging, our paper showing a big reduction in mortality. I think when undertaking PCI for bifurcations, whether it be left main or whether it be non-left main, you have to individualize your approach. This is an editorial that we wrote with Mirvat Alasnag from Saudi Arabia that couldn't join us this time. And really your decision making should be around whether it's complex or simple. If it's simple, then probably go for a provisional approach. If it's complex, I think a 2-stent approach. I don't think a DK crush is one size fits all. There are many other techniques, and you should very much individualize it depending on the characteristics of the main vessel and the side branch, angulation, and so forth. So this is the first case I want to talk about. It's a male patient, 47, ex-smoker, who's come in with this lesion. Fairly straightforward looking lesion, not much calcium there. The bifurcation angle of the diagonals, again, relatively straightforward, a 111 Medina. I elected initially to undertake a provisional approach in this case. So went provisionally, I did an OCT, size 3.5 distally, 4.5 proximally. I deployed the 3.5 by 28 millimeter stent in the LAD, potted with a 4.5 balloon. I'm not going to show videos, it's a straightforward case. There's the pot. The side branch was nipped, therefore I elected to do a final kissing balloon before potting again. This is what I got, and this is where imaging is really useful. So you can see that there's TIMI3 flow in the side branch. Many people would say, well, you know, great results, stop there. As I said, I always OCT everything, and this was no different. So I OCT'd this. And this is an OCT going from the main vessel into the side branch. And you can see that an extensive dissection in the side branch, as well as an MLA that's only about 2.5 millimeters squared. And you can see that, that the dissection extends quite far into the side branch. And a really nasty looking dissection. I don't think it would be appropriate to leave this. So immediately you can see that imaging has really changed how we're thinking about this case. So I undertook a T with a tap. Again, I'm not going to show videos, it's straightforward. And this is the final result. And I'm going to show you some more OCT. So this is the final result, good looking OCT result, a good looking image result. This is the OCTs, and the OCT is very useful here. Why is it useful? Well, first and foremost, it helps you check the results. You can see from this that, that in the tap, you can see that the stent has come into the main vessel, but not so far in that it's compromising or reducing the lumen. This is the 3D reconstruction. And again, you can see that your ostium is well covered, and you can see the stent coming into the lumen. This is the fly-through, which I think is a very nice way of using your OCT. It's 3D reconstruction. And you can see here that in your T with tap, you've got some protrusion of your stent into your main vessel. And you can also look at all individual struts here, see whether there's any malapposition by looking at red. You can look at the distal edge of the stent, make sure there's no edge dissection. I often use this 3D reconstruction, particularly when I'm wiring bifurcations, because it gives you a very good idea of whether you're wiring distally or more proximally. So I think it's a great use of OCT in a bifurcation here. Here is some considerations with T with tap. I think it's a good technique. I think you should aim for the shortest possible carina with tap. And I think the most important thing is when you pot is that you don't reach the neocarina, because you'll end up crushing the side branch stents. You've got to be very, very careful. Use stent boost. Here's another case. Now, you may say, well, why are you showing us this case? This is a really simple osteal lesion. This is a case of a patient who came in with an acute coronary syndrome. Many will say, this is not complex. I'm going to show you some data to actually show this sort of case has the worst outcomes of all bifurcation lesions. So the 001 cases have by far the worst outcomes. I will show you a paper, which is the first in the literature to look at this specifically, that hopefully is going to be published in the next 3 or 4 weeks from my group. So this is the case. So I elected to pre-dilate with a 2 millimeter balloon to create space for OCT examination. And you can see that in the distal vessel, distal side branch, a big vessel, 3.5 millimeters. You can see that at the ostium, just before the main vessel, very tight. And you can see that it's a 5 millimeter vessel. Now, there's many different ways of treating this. Of course, you could use a diagonal to LAD approach. You can then do a KISS. You can use a 2-stent strategy. But I want to also show you that you don't need to use a stent in these sorts of cases. And what I elected to do was use a 3.0 Wolverine cutting balloon and then a 3.5 drug-eluting balloon for a minute in this case. And this is the final result, so actually quite a reasonable result. And this is the OCT. So there is a localized dissection that you can see here, but the MLA is actually pretty good, and I don't have a fear of this closing down. So I was happy to leave it, and the patient was stable. And this is really why I want to say that really for these 001 lesions, I mean, we often see them. I would say that if at all possible, avoid using a stent in these lesions. And I'm going to show you the data why I think you should avoid stenting these lesions. And if possible, if you're going to treat them, use a balloon, a cutting balloon and drug-eluting balloon. So this is a paper where we've analyzed 4,000 bifurcations and the distribution of disease. It's the first time in the literature anyone has done this. This is going to be published in probably the next 3 or 4 weeks in JAHA. And you can see that isolated side branch lesions account for about 3.5% of all lesions in side branches. This is from the Ultimaster registry. And this is really the take-home message. You can see these are Kaplan-Meier plots of all the different Medina distributions of disease. And you can see that the one that has by far the worst outcomes, so a 5-fold increase in the risk of target lesion failure, cardiac death, target vessel MI, and target lesion revascularization are the 001 lesions. So, these are not benign lesions, stenting them. These lesions, if at all possible, avoid stenting them. This is 4,000 bifurcation lesions showing that they have the highest risk of target lesion failure and cardiac death out of all bifurcations lesions. Much worse than the 111s that we often consider to be the most complex. And so in summary, in my view, the choice of 2-stent approach really depends on anatomy. You need to think about the angle of the side branch, the size difference between the side branch and the main vessel, and the experience of the operator. We often talk about DK crush. Let us not forget, for those entering the DK crush trial, these were people that did over 300 procedures a year, every year for 5 years. There were people that did over 50 left mains every year for 5 years. And they also had to have their DK crush case assessed by a committee, and only then were they allowed to enter into the trial. So the results that you see from DK crush trials are from highly experienced, very selective operators. The vast majority of operators, myself, in this room, will not meet those standards. And so it isn't clear to me whether we can achieve those sorts of results in the real world. 001 is associated with the worst outcomes. It's not a benign lesion, much worse than 111 lesions. So if at all possible, avoid stenting these lesions. If you do need to fix it, then I think cutting balloon, drug-eluting balloons are very reasonable. Use OCT to look at the distribution of your dissection and your MLA, because a lot of these cases, if you get a good angiographic result, is safe to leave alone if you OCT. I think you should use imaging in every bifurcation case, particularly in the ostia, where most restenosis occur. And I think imaging is most useful to do it up front, in the middle, and at the end, because often it will change your management plan, as I showed in my T with TAP. Okay, so thank you.
I'll request Dr. Bhupati to step up for his presentation, and Ashok wants to take the.
So I think that, Mohammed, that's great concepts around two-stent strategy or provisional strategy. A couple of points and then a question to you. Firstly, of course, that the osteal lesions of a side branch are truly very difficult because you end up, if you do anything more than just a balloon angioplasty or a cutting balloon as you demonstrated, if you stent it, you actually sacrifice the main branch.
Yes.
And that's not a good thing.
Correct.
But I think in imaging, I think we need to emphasize that you always have to image what looks like the normal main branch as well.
Yes.
Primarily because if there's a bulk of plaque sitting there, then you change your strategy into what could be a two-stent strategy, what could be a cool-out, what could be any two-stent strategy. So I think the main branch imaging is equally important than just the osteal side branch imaging, which on angiography you think is 110, but may actually be 011 actually.
No, completely agree. And the other thing to say is never try to nail the ostium. It never works.
It never works, yeah.
So don't do it.
The second aspect was, are you a very hardcore provisional strategist, should we say, especially for the left main?
No.
Because I've seen operators who, even going by the definition criteria, would still not go by the definition criteria and just proceed to provisional strategy and falling back all the time on a bailing out of the side branch, which actually has a worse outcome than upfront two-stent strategy.
No, I agree. I mean, I'd say probably for most of my left mains, just because of the case mix that we have in my area, we have very elderly, multimorbid patients. They tend to be very calcific disease. It's very rare that you can get away with a provisional. I don't particularly do DK crush in all the cases. I think that part of the reason why they have worse outcomes in the Khaled arm, for example, is that most of the restenosis occurs in the ostium of the circumflex, and that's because people don't prepare the ostium properly. So in those sorts of lesions, I always use cutting balloon to make sure I have a good MLA, and again, image both arms at the end, and if necessary, use more aggressive balloon dilation to make sure that you've really got the best result.
Yeah. So simple for simple and complex for complex.
Yes. And that was the main difference between EBC main and the DK crush trials. I mean, many people say, well, they show different things. They don't. If you look at the average side branch length of EBC main, it was less than 10 millimeters. So by definition, it would be a simple bifurcation, which of course provisional is indicated for. Whereas in DK crush, it was, I think, about 15, 16 millimeters, the average length.
Excellent. One last comment from Henny, and Dr. Bhupati, would you like to step up? No.
Thank you very much. I just want to point out something, that you're in a position to teach, which you just did, which is quite unique. Because, for instance, where I practice, it's impossible for me to use an OCT in a side branch to avoid putting a stent, where the price of this OCT is about 4 times the price of the drug-eluting stent. So from a practical point of view, I can only see those things and learn, especially with data of 4,000 stents. And I don't know, probably most of the people in this room also would find using an OCT in a diagonal to avoid stenting it in our part of the world might not be applicable. So it's very good to see it and to get those levels.
So I would say to that, that we're trying to publish a cost effectiveness analysis of every PCI case in the UK, where we're looking at the cost with 1-year outcome data of imaging versus no imaging. Again, this only applies for the UK because we work in different systems. The costs that we use in analysis are different. But for the UK, use of IVUS is cost effective. You save more costs using it in every case than not using it because of the reduction in target lesion failure, restenosis, having to bring the patient back to the cath lab. That's costly.
Thank you very much. Thank you. A big hand for